Hello, it's me again. It's Val, and I'm on a roll today. So I've got my chronic obstructive pulmonary disease, little summary here, COPD, to go through. I did this one in under 2 hours. I think I'm getting better. Alright, so now we're looking at week 12 of the Notre Dame syllabus. And just to define what COPD is, it's an obstructive lung disease which is caused by either destruction of lung tissue, which is seen in emphysema, or scarring of small airways, such as seen in chronic bronchitis, and this leads to gas trapping and lung hyperinflation. So there are two COPD kind of diseases that I'm going to focus on today. We've got emphysema and chronic bronchitis. However, I just wanted to note that asthma and bronchiectasis, which is kind of minor collapse of bronchi due to loss of elasticity, those are also types of chronic obstructive pulmonary disease. So starting off with emphysema, so these are the more kind of extreme ones, and they're not really reversible using bronchodilators. Not completely reversible, at least. Alright, starting with emphysema, we've got here the classic picture of a person with emphysema. We've got someone who's kind of skinny, they've got a big barrel chest, which is where they've kind of got this large horizontal width of their chest. And they also have a small heart, which is, somewhere like that. Which is usually, it's not really a cardiac issue, but it's more because their lungs are so hyperinflated that it's pushing on their heart. So in terms of pathophysiology, it usually starts because there's some kind of anti-protease deficiency. So imagine here we've got our normal cells, ignore CD20 and CD3. We're thinking neutrophils, we're thinking macrophages, we're thinking any leukocyte that produces these enzymes called proteases, such as elastase, that can break down elastic tissue in the lungs. So usually they secrete these proteases that break down bacterial and viral and any pathogenic substances. But during inflammation, we usually have proteins called antiproteases to prevent these proteases from impacting our own lung tissue. However, if you have a deficiency in these antiproteases, either through genetics or through cigarette smoke, and that is alpha-1 antitrypsin deficiency, which can lead to panasema emphysema, or cigarette smoking, which can lead to century acinar emphysema, you're going to get an increased number of these proteases, which aren't being inhibited, and so your inflammation is going to lead to lots of tissue destruction. And so what we're going to see is, so this is our alveolus here. We are going to see dilation and destruction of the alveoli, which leads to a decrease in surface area that is needed for, or that can be used for respiration. We're going to see a decreased elastic recoil of the alveoli due to the degradation of the elastin. And you can even get the formation of bullae, which are these macroscopic dilations in the lung where, so much lung tissue has broken down that we're now seeing these big bubbles, air-filled spaces in the lungs. Microscopically, we're going to see these big, large alveoli. We're seeing really small, skinny septa, and we see a decrease in the capillary beds because elastin is also a component of the microvasculature wall. And then in terms of signs, what you might see in someone with emphysema, you might see some pursed lip breathing because they want to increase the airway pressure to keep their lungs inflated. You might see tripoding, which is where they place their hands on their knees in order to engage their pectoral muscles, as these are accessory muscles. You might see reduced breath sounds. The chest might be hyper-resonant to percussion due to the increase in air-filled spaces. And in late disease, you might even see right heart failure with pulmonary hypertension, aka cor pulmonale. On chest x-ray, this is more of a picture of someone with emphysema, but it would look similar in chronic bronchitis. You're going to see things like a hyperinflated lung, so you can see more than 8 to 10 posterior ribs in this x-ray. You're going to see a flattened diaphragm, again secondary to that hyperinflated lung, and a narrow heart. So you would see, I think, I can't remember exactly what axis deviation this would be, but you would see an extreme axis deviation. Basically, it would be like going straight down in your ECG. And then this is a lateral view where you can see how rounded and barrely the chest is and how flat the diaphragm is and how overinflated the lungs are. I feel like you could fit like an entire party in this person's lungs. It's crazy. Okay, so that is our pink puffers, aka our emphysema. Now, moving on to chronic bronchitis, which is another subcategory of COPD. This can be defined by a chronic productive cough for most days of the year for more than 3 months and more than 2 consecutive years. So these people usually present as what's known as blue bloaters. They're obese, they're usually cyanotic by a process that I'll explain why, and they have a larger heart. So pathophysiology-wise, what usually happens is that you'll get long-standing irritation by tobacco or other particles. So you can also get chronic bronchitis from coal dust inhalation, which can cause constant chronic inflammation. You'll get hypertrophy of submucosal glands in the trachea and the bronchi, and an increase in goblet cells in your smaller airways. This leads to sputum overproduction, and due to a decrease in surface area due to sputum production, you get a ventilation perfusion mismatch, and you get hypoxia and hypercapnia or CO2 retention. So in terms of what this looks like pathologically, you're going to see things like the narrowing of bronchioles. You're going to see chronic inflammation, a proliferation of glands, goblet cells, and smooth muscle thickening. And you can see that here on this nice little histology slide where we've got increase in submucosal glands. If you zoomed up really far, you would see an increase in goblet cells. And all of this here is mucus overproduction. You can see that's basically shedding into the lumen of the bronchiole. We also see a dilation in all of these blood vessels. That's like the congestion, the vascular congestion. And all these little dots around here are all lymphocytes that we see infiltration of. So that's our signs of chronic bronchitis. Now, in terms of signs for chronic bronchitis, as well as the pursed-lip breathing and tripoding, you're also going to see more cyanosis due to the hypoxia. So that's going to be a bluish tinge to your lips and your tongue. You're going to see carbon dioxide retention symptoms, such as asterexis or the flapping tremor at your wrists. And you would also, on a blood test, get an increase in red blood cells and hemoglobin, aka polycythemia, due to the chronic hypoxia, which is stimulating erythropoietin release and therefore more erythropoiesis. But of course, if you can't breathe properly, no matter how many red blood cells you have, you're not going to get better. So just to conclude, we have a nice little flow volume loop here, which is characteristic of obstructive disease. So usually a flow volume loop would look something like this. You breathe in, you breathe out, you breathe in. But in obstructive disease, when you breathe, when you breathe out, you have an You have a problem with getting out the first few parts of your breath because you kind of get that like resistance of your airways. Oh, that was a terrible explanation. Basically, you're going. That was a better explanation. Oh, that was pretty terrible. Anyway, and a characteristic finding in your spirometry is that you're going to, in your peak expiratory flow rate, is that you're going to get a FEV1, or forced expiratory volume in the first second, over your forced vital capacity. This is going to be more than 70% below normal. Just realize that says. Yeah. Okay. So yeah, that is COPD, and that is week 12. And yes, to future me, if you're watching this, I hope you understand it better, and I hope the people that you see with this get better soon. Oh yeah, and just to mention, if you're going to be treating these people, you're going to be giving them acute bronchodilators, beta agonists, or anticholinergics, for example. And in terms of long term, you might give them corticosteroids and get them to reduce their smoking if they smoke, because that is bad. Yes, anyway, that's it from me. Thank you for listening. It is Val, signing out.